huge thank you to Abbott for sponsoring this session. We've got a very excellent speaker for you today. Mark Pearson is at RWJ Barnabas. He's been a perfusionist for 30 years and 25 years spent as chief perfusionist. He's just sort of saying that he does heart transplants, ECMO, lung transplants. So it's easier to list what he hasn't done, which isn't really much. So it's a pleasure to welcome to the stage, and thank you for your experience and sharing it with us.
Thank you, Richard. Appreciate the introduction. Good afternoon, everybody. It's good to see you. I have to say I was here for the morning sessions, and I was laughing at Keshav's talk about LVADs and flow dynamics and all of that. I don't know if you recall, but if you were in here this morning, you mentioned that his students knew all about LVADs because they had seen them on Grey's Anatomy. And as it happens, I have a 21-year-old college junior daughter who has announced to me that she knows all about cardiopulmonary bypass. She knows all about ECMO, and she learned it all because she's watched Grey's Anatomy. I'm not sure how many times over. So I'm here to tell you that we're all wasting our time. We should be home. We should be at the pool. You're wasting your time being at these scientific sessions. Really, all you need to do is go home and watch Grey's Anatomy. Nobody leaving? All right, well, we'll get started then. So I want to thank Abbott for the opportunity to be here today and spend just a few minutes with you talking about their new pre-connected pack. As Richard said, we've been doing ECMO for a long time now, and we've used all different kinds of circuits, and this is one that we're particularly excited about. And so let's talk about it. Disclaimers, I am here on honoraria from Abbott, and but what I'll tell you is that everything here is my opinion. No one has prepped me or given me anything to say, and frankly, the honoraria is not nearly big enough if they wanted to. So what you'll get is our experience. We are a very large healthcare system in the state of New Jersey. RWJ Barnabas Health is the largest healthcare system in the state, one of the largest in the country. And 4 of our 15 or so hospitals are engaged in cardiac surgery and ECMO and the like. And I've been here for 25 years. And I'll start by telling you that when I got to my present position, we were the only ECMO center in the state of New Jersey. How many of you do ECMO right now? It's the last question I'll ask. A lot of hands going up. If I were to be able to see all of our remote listeners, I'm sure a lot of people sitting on their couches at home or out at the pool right here, watching on their phones, they raised their hands too. When we started, we were the only program in the state of New Jersey. And 25 years ago, our program looked like what many ECMO programs look like. We were in the NICU, we were in the PICU, and we were very seldom in the adult ICUs. Today, that's completely turned. Several reasons for that, I think. I'm happy to say that many of the kids in the NICU and the PICU no longer require ECMO. The advent of inhaled nitric oxide, I'm sure that's changed many of your practices. It certainly has for us. You know, meconium aspiration kids, hyaline membrane disease kids, these kids very, very rarely go on ECMO anymore, I'm happy to say. Lung protective strategies, ventilation strategies. When I started in perfusion and we had a NICU kid who came in from somewhere outside who was experiencing respiratory distress, first thing we did was paralyze him. We put him on high pressure ventilation and we tried to drive that oxygen right into the lungs. Today, if you tried to do that, they'd drag you out of the ICU, right? We've come to the realization that volutrauma, barotrauma, those are very real things and that they should be avoided. So we have lung protective strategies. We have synthetic surfactants today, which have also helped us quite a lot. So suffice to say, we don't put a lot of kids on ECMO today. But as I said, we went from about 1 program in our state to a dozen programs in our state, all doing adult ECMO. So I wonder what could have changed. Well, if you've been around for a little while, if I mention the word Caesar trial, that probably rings a bell. If you want to know my opinion on the Caesar trial, I'm happy to share it with you about its design and data collection, and you just meet me in the bar and bring me whiskey and I'll tell you all about it. Another thing that I recall happening, I don't know, a dozen, 15 years ago was the H1N1 epidemic. Everybody remember that? It's been around for a little while. You remember that one? We had a whole line of patients on VV ECMO in one of our ICUs that were all H1N1, and we discovered that we could really help a lot of these patients. Then COVID came along. We did a lot of that, right? So, but I wanna start by, let's just look at this slide here. And if you raised your hand that you do ECMO, then you're using some sort of equipment. If I'd have gone to the perfusion meetings in the United States 2.5 or 3 years ago, and I were to survey the audiences and I were to ask what is everybody using, especially as far as oxygenators are concerned, to support their patients, do you know that 90% of us would have all said the same thing, right? If I'd have gone to the perfusion meetings in Europe, I suspect it would have been closer to 80%, but still an awful lot. They had a market share at the time that we received a letter saying that we should not be using these devices anymore and we should look for alternatives. They probably had a market share of 90% at least in the United States. And I don't know about you, but that struck fear in my heart, because we do on the order of 75 ECMOs a year, which doesn't make us a huge center, but it makes us a pretty good size center. And so we do a lot of ECMO support. And I was thinking, how are we going to cover these patients? Well, you'll see what our answer is here. The other thing that I note about the market conditions, I don't know if you feel the same way, but have you noticed that our supply chain hasn't recovered from COVID as quickly as we have? Is that true? Do you see back orders? Do you see difficulty in getting things? We used to order certain supplies and get them within 2 or 3 days, and now I don't know if they're coming in 2 or 3 weeks or 4 weeks or what. And so, and then there's this other thing. I'm not going to get political, but I don't think we know yet what the fallout's going to be from whether or not tariffs affect our business or not. All right, so you're all perfusionists or perfusion students who are brilliant, and I know you know all of these things. I know you know the risks and complications of ECMO, but I think it's a place to start when you're talking about circuits. I'm not going to go through all of these. Each one of them could probably be its own talk. I'll mention 2 of them just to kind of get the ball rolling. One is the knife's edge that we walk with regard to thrombus formation versus bleeding. And since this is an industry-sponsored talk, I'll start by saying I don't know of anyone who makes any of this equipment who would ever say that it's okay to use it without anticoagulation. But I know you're doing it. I know we're doing it. I know that it's out there. And so that knife's edge just got a little bit sharper, right? And the other one I'll make a comment on is limb ischemia. All of these things that are on the list are things that you think about. They're things that you need to strategize about. And I hate to tell you, but if you do a lot of ECMO, there are also things that, as careful as you are, you're likely to see over the course of your career. We've had all of these things over the course of our time. Not every year, but over the years, we certainly see all of them. But I will comment on limb ischemia. About half a dozen years ago, we started putting distal limb perfusion apparatus in all of our peripherally cannulated VA ECMOs. And we went from about a 20% limb ischemia rate to darn near 0. I won't say it's 0, but it's pretty near to 0. We use a 6 French 11 centimeter wire reinforced catheter that we just put into the distal femoral, and it works great. We use a little piece of high pressure tubing, connect it to the port on the arterial cannula, and we let it do its thing. And so those are the only two that I'll point out here. But as you know, you need strategies to deal with all of them. So we're going to talk about an ECMO system today that, if you haven't gone to see it yet, is next door in the exhibit hall. After lunch, I'll give you a little preview. There's going to be dessert in the exhibit hall. So you need to get over there to the exhibit hall. And they're closing at 3 o'clock today. So I'd say after this, grab some dessert over there, swing by the Abbott booth if you have any questions. And the other thing I'll say is, when you come to meetings like this, I'm sure Richard will tell you, we are dependent upon those exhibitors over there. So if you haven't taken the time to go and visit all of them, you probably should. These kind of things aren't really possible without the support of the vendors. And so it's a good way to say thank you and to ensure that we continue to have these great meetings by making sure that you swing by those booths. So I'd encourage you to go see all of them before you head to the pool. All right. So as far as ECMO goes, they all have certain things in common, right? We know that we need a way to oxygenate and ventilate blood. We need a way to propel blood. We need to convey it in tubing. We need cannulas to access the vascular space. And the question marks on the other two, the heating device and the monitoring, it's not because they're questions, but it's because if I were to sit with all of you, we probably all do it a little bit differently. Our program, just for example, especially on adults, I'm talking about adults here, not children, but we don't put a heater cooler on every circuit. That's an argument. That's something we could talk about. I fully appreciate the opposite side of that. We put it on a lot of patients, but we don't put it on all the patients. And so I think there's variability there. Same thing with monitoring. There is a lot of variability in the way we monitor these patients. So in my mind, if you were to start an ECMO program today, you've got three basic choices about what you put on your shelf to be ready. Maybe you're at a program that doesn't have an ECMO circuit, but you're concerned that every once in a while you'll have that patient that you can't get off of bypass. And if you've been doing this a little while, you know that you really can't predict who that's going to be. It's not the patient you're worried about, I can tell you that. It's the one you're not worried about. That's the one that's going to have the problem, and you're going to have to be able to take them from bypass to something else before you can get them out of the hospital. And so maybe you thought, well, in order to do that, I'm going to put a box of oxygenators on the shelf. I'm going to have some sort of a pump on the shelf, and I've got a bunch of tubing lying around anyway. I can build my own thing. It's an option. I'm not saying you can't do that. It's definitely an option. The other thing, and a lot of us have done this over the years, is we've created our own custom packs. If you're in a position to be a leader, you know how that's done. You call your sales rep in, he sits down in your pump room, you get a bunch of tubing out, and you build something. He's writing down, or she's writing down, they create a spec, and 4 or 6 weeks from now, they show up back at your hospital with a non-sterile sample. You shake it out, you put it on your system, and you look at it, and you either bless it and say, go ahead and build it, or you make whatever changes it's going to be. But in the end, 10 weeks after you bless it, you've got your own custom pack that sits on the shelf. It's a good option, and that we did it for years, and we still have it for certain occasions. And then the third option is the one that I want to concentrate a little bit more on today, which is a readily available, commercially designed, pre-connected pack that we've been using now for the last few years quite a lot. And so I want to show it to you today. If you haven't seen it, I think you're going to like it. If you have seen it, I still think you're going to like it. Options 1 or 2 are viable, but they require you, especially in a program where you don't do it very often, to gather supplies, to put something together that maybe you're not that used to putting together, maybe you haven't done it as often as a busy center would. And it requires you to go to the shelf and to grab an oxygenator, grab a pump, grab packs. You got to assemble things, put it together. You may need to grab a reservoir. And when things aren't going so well, I think that it's time better spent on other things. And so we've moved away from that to this pre-connected pack. I'll tell you a quick story about a telephone call that I got several years ago. It was from a surgeon that used to work with us. He had an opportunity to go to another program. He became the chairman of cardiothoracic surgery there. Good opportunity for him. He went away. About 2 weeks after he got there, he called me up. He said, you know, Mark, I've just been sitting down with my new chief perfusionist over here at my new program, and beyond a balloon pump, we don't have any way to support a patient mechanically that either runs into trouble getting off the heart-lung machine or comes in through the ER or some other route. Somebody crashes in a cath lab, whatever. We have nothing here to support that patient. What would you recommend? I told him that I would recommend that he got CentraMag. The reason is versatility. He was only going to buy one device. He didn't have a lot of money lying around to buy multiple devices, and so he was going to buy one device. I said, you know, with the CentraMag, you can support patients who need RV support. You can support patients who need LV support. You can support patients who need BiVAD support. You can put people on ECMO. You can use it as a bridge to transfer somebody to a transplant hospital. He wasn't in a place that was doing transplants. You can use it to get somebody to a place where they can get a durable VAD. They weren't doing durable VADs. I said, you can send them to us. We'll take your patients. And you can use it to put patients on ECMO. And so my advice was to buy that one system, which is what he did. If I got that phone call today, for reasons that I'm going to show you, I'd be even more committed to that advice. This just talks about some of the history of CentraMag, but this is what we really want to talk about. This is over in the exhibit hall, as I mentioned, and we've been using it in our program for a while now. We'll tell you a little bit about our usage and our results and why we like it so much. So here's how it comes. Those of you who have your own custom packs, this probably looks fairly familiar to you. Comes in a nice suitcase box. You open it up, and inside is a little bathtub with a cover that you peel off, and everything that you need, except for cannulas, is in the box to put somebody on ECMO. So quick and easy, and when you open it up, this is what it looks like. Can you see that pretty well? I think you can. So rather than going to the shelf, grabbing a pump, grabbing an oxygenator, grabbing a tubing pack, everything is here. Your least experienced team member can open this box and hang that thing up. If it takes them 2 minutes, they're not hurrying. If it takes them 1 minute, they're probably a little above average. It literally sets up in a minute or less. Everything's pre-connected. You've got your priming reservoir, your pump, your oxygenator, your AV loop, everything is there. You pull it out of the box, you hang it on your IV spider, you put your oxygenator in the holder and your pump in the motor, and you're ready to prime. You literally grab a bag of whatever it is you're going to prime with, and you're ready to prime that circuit in a minute. It probably takes you another 3 or so minutes to prime it. I'm one of the older perfusionists in the room. It hurts me to say, but as I look around the room, I'm finding that's true. But I'm not the oldest, which means that some of you remember using the Meds. You remember those? You remember those? You didn't prime those in 3 minutes. We used to CO2 flush the heck out of them. In fact, some of us even used to vacuum prime them. They're not like these modern circuits today. This thing primes up in 2 or 3 minutes, and you're standing there at the bedside ready to hand lines up while they're still getting the patient draped. They haven't anticoagulated the patient yet. They haven't put the first needle in to pass a wire, and you're ready to go. All right, that's a pretty good feeling. So, as I said, if I'd have asked you 3 years ago what oxygenator were you using, I would have got the same answer, right? Most of you would have said we're using the Quadrox, which is fine. And then something happened, recall occurred, still not back. And so for me, doing 75 ECMOs, I was pretty nervous at that point. I was not sure how we were going to support those. I see heads nodding out there. Yep, kind of a nervous feeling when that letter came across. I had already tried this oxygenator. We knew that it worked. And the first thing we did was we started ordering a bunch of them. You know, it's a polymethylpentane oxygenator with a proprietary coating to make it less thrombogenetic, less complement activation, a little more friendly to the blood, and it's readily available. And I got to tell you, I was a little nervous. I thought once this other device went off the market, I wasn't sure that we were going to be able to get them, so I ordered a bunch of them. I ordered a bunch of them, and they said, Mark, we're not going to send you that many. You can't have 50 of them. So I didn't get my 50, but I got a bunch of them, and we've been using it ever since. We'll talk a little bit more about the oxygenator in a minute. So sometimes I get the question about why do we use the CentraMag blood pump for ECMO? I mean, truth of the matter is I've got a centrifugal pump in my OR that costs about $200. This thing costs several $1,000s to use. When you see our experience, I think you'll get a clue as to what the answer is. But the engineering of it provides the answer. This thing is completely magnetically levitated. All right, so the cone the cone is made of a durable plastic, but the rotor inside never touches the sides. It's completely suspended through magnetism. As soon as you put it in the motor and you power it up, it powers the magnets in the motor, and it suspends the rotor in the column of blood. And so there are no bearings, there are no seals, there are no pivot points in there. There's nothing that contacts anything on the pump housing at all. What it does is it provides nice wide gaps for the blood to flow through. And that positioning is there are sensors in every plane of that rotor, up, down, side to side, and it literally measures the position of the rotor tens of thousands of times per second. So it's, in my mind, capable of going more than it's built to go lengthwise. Not sure what I can say about FDA approval, but we've used it certainly off-label much longer, and it's the reason that we spend the money on this particular pump. And you'll see when we talk about our history with the device that we've run this for pretty long. In fact, I was at the talk right before lunch. Dr. Giles, I don't know if you saw that, he was telling us a story about this baby that he had supported with a CentraMag system. Baby was on ECMO for 258 days and they didn't change the pump. So that's why we spend the money on this particular device, because we don't know how long these patients are going to be on it. If you use CentraMag, this might look new to you unless you've recently purchased motors. The blue parts there, these blue tabs replace the little set screw that used to be on the CentraMag motor. We love it. Our guys love it. It's much easier to put the pump in and get it locked into position. You know, if you recall, you had to put the pump in, do a little quarter turn, and you had to get that set screw to line up in one of the notches. And we're one of those programs where we'll take patients from all over the region. We're kind of one of those hub and spoke deals where we'll get patients from hospitals all around us. And sometimes they've been cannulated by people that aren't us, and we'll get them in. And I can't tell you how many times that set screw is not where it's supposed to be. And we just took this guy, you know, on a road trip. So I think this is an improvement. I think people are going to like it. And I know our guys do. So with regard to that phone call that I got, you know, here's a versatile device, and if you're only going to buy one, I would stick with the one that I recommended, CentraMag, even more so today. because when we bought the original CentraMags, if anybody remembers the first generations, they didn't look like they do now. They kind of look like a turtle. We go that far back with them, and we were using them as LVADs and RVADs and BiVADs, and we weren't really using them for ECMO yet. But now that we are, our program supports patients from neonates to octogenarians, and we're everywhere in between. Now, when you see our experience, you'll say, well, but you haven't put a neonate on ECMO with the pre-connected pack yet, and that's true, we haven't, but it's just a matter of time. And we've got all of these oxygenators on the shelf. They make an infant, a pediatric, and an adult. And so what it means to me is I can support our entire range of patients from neonate, 2-3 kilo patient, all the way up to our largest patients. And I don't need to buy more capital equipment. I can use the same motor, I can use the same console, and I've got an adult and a pediatric CentraMag pump, CentraMag and PediMag, and all I have to do is change that and use a smaller circuit for the smaller kids, smaller tubing, smaller blood pump, but the capital stays the same. No need to go out and purchase additional equipment. So the versatility of this thing is maybe better than it was when I first made the recommendation. And so we're thrilled with the capabilities of it. So this is a question I always get, right? You showed a slide that shows 3 oxygenators, and if you wanted to take a picture of this, here's the one that's going to give you all the specifications that you need, blood flow, etc. But take-home message for me is that I can support anyone from 200 milliliters per minute all the way up to 7 liters with the same console, the same motor, and the same platform without having to spend any more money or make any more changes. So here's why our staff likes it. Our administrators like it because I don't have to buy a whole bunch of extra equipment, but our staff doesn't really care about that. What they care is at 2 in the morning when they have to employ it, how user-friendly is it, okay? So the first thing is, and this is cool, I don't know why everybody doesn't do this, but the AV loop is color-coded. There's a strip that's in the tubing. One of them's blue, one of them's red. Now, I'm a perfusionist. I know that somebody in a factory is putting this together. So I'm a trust but verify kind of guy. Belts and suspenders, whatever you want to say, right? I always trace it to make sure that it's right. The blue tubing is supposed to go into the circuit. The red tubing comes out of the circuit, okay? I don't use terms arterial and venous because sometimes it's all venous, right? Sometimes it's VAV, you know, so I don't do that. Inflow to the pump, outflow from the pump. Inflow to the pump tubing has blue, outflow from the pump has red. And it's not that important to us as perfusionists, but when you're on the field and you got 2 pieces of tubing and they're the same size, and you know that sometimes the circumstances of cannulation are not so smooth. Sometimes there's a Lucas device going. Sometimes there's somebody trading in and out with CPR. It can get a little chaotic. Sometimes you're not in the place that you really want to do this. You might not be in an operating room. You might not be in a cath lab. You might be in the bay of the ER. We've certainly done it in all of those places. And so it can get really confusing. And I can tell you that the guys at the field really, really like this. Now, verify it. We've never seen one set up backwards, but I always say trust but verify. But it's a great thing to have. The obvious thing is that all the components are pre-connected. You take that thing out of the box and you hang it up and it's ready to be primed. Setup time, like I said, I can set that thing up in 30 seconds. Our slowest person can do it in a minute. So it's not a consideration. Priming, another few minutes. So people talk about this, right? There are some circuits out there that are pre-connected circuits, but they're pre-connected in a different way, right? So you can't necessarily change out individual components in every circuit that's on the market. They're great circuits. We use them all, believe me. But there is something to be said for having the ability to change out an individual component. Now, if you need to change out an oxygenator and you're pretty good at it and you've practiced it and maybe you've done it a few times, it's 2 wet-to-wet connections and you're on a new oxygenator and you haven't disturbed any of the rest of the circuit at all. And so, I don't know, some people think that that's important. I think it's a nice thing to have. And so I see it as an advantage to this circuit over some of the other pre-connect circuits that are out there. So let's talk about our story a little bit. I've told you it's a nice thing, but how are we using it? So we're very early Centromag adapters. As I told you, we went to the first generation. I've been in this job 25 years. As soon as it became available, we bought it. We bought it as soon as it came on the market. As soon as then Thoratec purchased the technology, we bought it. We're a VAD center. We have extensive mechanical circulatory support experience. If you can name a VAD, the chances are we've put it in. We've done every generation of HeartMate. I go back, I told you, I'm kind of old now. I go back to the original pneumatic HeartMates. They were about this big, and the patients would push around a pneumatic driver because they were driven by air. They were big. There were a couple of iterations along the way, the SNAP, the VE, they moved to electric, HeartMate 2, HeartMate 3, we've done all of those. Every kind of VAD you can think of. We've done Jarvik, we've done Micromed DeBakey, we've done Heartware. We have done all the old temporary devices. Who remembers the BVS 5000? You got to be around a while. Yeah, so there's a few guys out there that can remember those things. So we have a lot of VAD experience, and which means we have a lot of sick patient experience. We've supported about 150 patients with this pre-connect pack. And I suspect that the next point might surprise you a little bit. We've supported our longest patient on a pre-connect pack is 97 days. We've had COVID patients on other circuits that have gone longer, but so far on a pre-connect pack, this is our longest support. This was a young woman, postpartum, had a healthy baby who herself became critically ill from a pulmonary standpoint. We put her on VV ECMO. She was on for 97 days. We weren't sure what was going to happen. She was pretty slow to recover, but I'm happy to say she's home with her baby now, doing very well. And so she's a success story. And 97 days, we didn't change anything out on her. In fact, we've only changed 3 oxygenators out. So that's, I think, pretty good record for 150 plus supported patients. And I'll tell you, 2 of these changeouts were on the same patient. They were within a day of each other. And I don't think we could have had any circuit that this patient would have tolerated. Just thrombosed everything, not just the circuit, but I mean everything. Was an unfortunate outcome. But I don't think we can blame the circuit. So 2 of those changeouts are on the same patient. Since then, we've only had 1 other change out, and none of them have been emergent. They've all been, well, the 3rd one wasn't emergent. I'm going to say that the 2nd one was emergent on the first patient, but just didn't work out. So, but pretty good record, I think. If you want to calculate the percentage, I think it's pretty tolerable. We've used it for VA, we've used it for VV, we've used it for VAV, we've used it with dual lumen catheters, we've used it peripherally, we've used it centrally, we've used it pretty much every way you can use it, I think, and on every type of patient. So if you ask me if it works, I'm going to tell you yes. So far, we've only used it on adult patients. I'm a little bit surprised by that. Of course, my phone's going to ring in about 5 minutes to tell me that they're sticking it on some, just because I brought it up, right? That's how it works. But so far, only adult patients. We're ready. We've got the PD mag. We've got a small 1/4-inch circuit, so we're ready to go with it. But so far, only adults. So here's a question that I get asked once in a while. So we do 75-ish ECMOs a year. And so whenever we have a patient on ECMO, we have a prime circuit that's at the ready as a backup. If you were to come to our hospital, you would find out that for adults, we put patients on ECMO in 3 separate units. We've got 3 separate ICUs, any of which has the capability of having ECMO patients on it. And so if we've got patients on 3 different units, we'll have primed ECMO circuits on 3 different units as backups ready to go. You could add 2 more units if you include the PICU and the NICU, but those circuits are a little different, and we would have prime backups there too. But it kind of begs the question, well, how long do you keep your primed ECMO circuits? Because as I showed you, we don't change a lot of them out, which means those backups are sitting primed. And so what we do is we keep them for 30 days. We prime them and we keep them for 30 days. Well, that's a policy that we had to write, and we needed a little bit of air support to create that policy. So I found this study here. I thought it was pretty interesting. Basically, what it shows is this is a study in which they took pediatric circuits and adult circuits. They set 2 each pediatric and adult circuits up utilizing aseptic technique. They covered them, and 65 days later, they came back and cultured them. 3 separate cultures, 3 separate types of plates to make sure that they understood that, you know, if anything was growing, they weren't going to miss it. So they cultured all 4 circuits, 3 separate culture media, and they grew nothing. I actually have another type of a policy for my heart-lung machines. We'll only keep a primed heart-lung machine for 7 days, but I found a study in Japan that kept them for over a year and grew nothing out of them. So I think there's good support to have prime circuits that can at least be safe for that long, particularly ECMO circuits. Now, I wouldn't use a microporous oxygenator that was longer than 7 days. I'm not really so concerned about growth because I think that's been proven, but I'm not so sure about function out beyond that. So the PMPs, I know they function great, at least at 30 days. But I'm not so sure I'd use one of our OR oxygenators out that long. I'd be concerned that it might wet out and we might start having a performance issue. Okay, we're getting to the end. We're getting to the point where I give you some advice if you want to consider using this device. First thing is, as I'm sure you know, all of these circuits are gas sterilized. So when you set up your heart-lung machine, what's the first thing you have to do with every Luer lock? You got to tighten them, right? They're all loose. They're loose on purpose. That allows the gas to get in and sterilize your circuit. No difference here. So what we do is when you open that top, just go in and tighten up all the Luer locks. They're all going to be loose, and it's done on purpose so that they can be sterilized. But they're all going to be loose, particularly if you're going to set this up as a backup and you're going to use it for a while. Last thing you want is a cap falling off. It's not really aseptically set up at that point, right? So just go in and tighten them all up. Don't forget to remove the vent cap on this thing. You'd say, well, why do they put a vent cap on here anyway? Well, I think it's to protect it during transport. I will tell you that there's a little side port on the exhaust. So if you forgot, it's very unlikely that you would pressurize it, but best practice, right? So just don't forget to remove that. It comes with a cap on it. There's value in the cart. You know, sometimes I'm a little cheap. We bought these circuits. We didn't buy the carts for a little while, probably about 18 months. We were doing all sorts of things to put the circuitry on all kinds of different things. Then we bought a cart, and now we bought a bunch of carts. They're the greatest thing. In fact, I'll tell you, you can see that the primary console is on top, the backup on the bottom. It doesn't have to be that way. You can put them, you can stack them on the top shelf. You can remove that bottom shelf, and the smaller heater coolers will fit right in there on the cart. Your small Cardio-Quips, your Cincinnati Sub-Zeros, whatever it is that you have, they'll fit right in there. And so that's a nice thing. Yeah, just what I said. All the backup equipment fits there. It's great for ambulating patients. I don't know how well it shows up on the slide, but there's a really solid handle. The wheels are out wide. You can't tip it over, even if it's kind of top heavy. If you put things up there, you really won't tip it over. It's good for supporting patients if you ambulate your patients. We do some of that, and this has been helpful. There are also advantages to the monitor. We don't have enough monitors for every one of our consoles. We have about 20 consoles, so we don't have 20 monitors. But when we have a patient on support that doesn't have a monitor, we really miss it because it's great. First of all, you can control all the pump parameters with the monitor. You don't have to go to the console to make your changes. You can do it right on the monitor. The other thing is, it was really great during COVID because you could turn that monitor, and we were trying to limit access to the room. We weren't going in there as often as maybe we would otherwise, but you can see it very well from the doorway. It's great on patient rounds. When people are coming around in rounding, they can see right from the doorway what the parameters are. So the monitor's not that expensive, and it really is nice to have. And so that's pretty much it. That's our story. If you want to see this thing, I'd say go next door, and go next door anyway. Go see all of the vendors. And if we have a little bit of time, I'll take any questions or open the floor for discussion.
First of all, thank you very much.
Thank you. You got one? All right, go ahead.
In the pre-connected pack, which pressures are you monitoring?
I knew somebody was going to ask that question. We don't monitor pre and post pressures. As you know, the CentraMag has the capability to do so. You can plug transducers into the CentraMag and monitor pressures. On this circuit, we don't monitor pressures, but we chart every hour. We have perfusionists at the bedside. We're watching RPM versus flow versus SVR, blood pressure, all of those things. And so we feel like we're pretty able to see if we're starting to get obstructions to flow. The other thing is, some of these patients are on fairly chronically. As you saw, we had this patient on 97 days. We had some COVID patients on 120 days, and I'm sure some of you could probably even beat that record. So anytime I need to go into the circuit, I'm cautious. It's a risk of thromboembolism, there's a risk of air, there's a risk of infection. And so on this particular circuit, we're keeping it very simple. We've done hundreds of them, and we have not felt the need to monitor pre and post pressure from the CentraMag. So we don't. Some people might disagree with that. You certainly do have the capability. One more, sure.
With the supply chain issues, just observationally, I've never been unable to get a CentraMag.
I never have
Never,
either.
Personally.
I'm not sure how they're doing it because I've had difficulty getting a lot of things. I have not either.
Just with experience, I know we had a system where we hung up the ECMO circuit completely, steadily put together, and we left it for a year, again, with no problems in terms of growth or anything like that. So
you tested it after a year?
Yeah. It was fine. I mean, I wouldn't put it on a patient after a year, like you say, but that's a different matter. But we routinely hang our circuits and leave them for 30 days. Almost invariably, we'll use them, but we'll hold them there. It's just, especially for emergencies, it's very quick and easy to use.
I think it's perfectly safe. I have to say, for us, we rarely waste a circuit. We just put enough patients on. We'll have half a dozen going at a time, and so we rarely waste a circuit.
There was a comment on the chat earlier that I'm pretty sure I know the answer to this is, do you feel confident using the oxygenators up to bigger patients? Yeah, so I can tell you that since I've been here, we've taken a patient off ECMO who weighs about 436 pounds. He's been on a pre-connect pack for 20-something days, came off since I've been here, and is doing nicely and was well supported with the device. Now, because of his disease process, he kind of was hypercapnic at times, and we ran our sweeps pretty high, but we had no trouble oxygenating or ventilating the patient, albeit our sweeps, were in the 8 and 9 liter range for part of the support.
One over here. Okay, so, yeah, go ahead again. So I am loath to put CRT into our circuits. Have we done it? Yes. When we used to be less busy, we did it more often because we were pretty much one-to-one on circuits. But very often now, we're a perfusionist monitored program, and very often a perfusionist will be watching multiple. My theory on ECMO is that ECMO is designed to provide cardiac and/or pulmonary support to our patients, and that's what we use it for. We don't use it as a manifold. We don't use it as a dialyzer. We don't use it to run CRRT through as a rule. Every once in a while, I'll get a call from an ICU doc who says, you gotta help me. I can't get a line in. There's just no other way to do it. And we do it. But we really hope not to do it. And we go high pressure to low pressure because I want the return to be pre-membrane. The CRRT machines hate that. They don't like to see high line pressure. They see it as abnormal because normally you're hooked up to like a triple lumen catheter, which is a low pressure system. So now I'm sending volume over to it with a line pressure of 200, and it really doesn't care for it. And so I'm not so sure that it works great anyway. And because of the number of patients that we might be monitoring at a time, we'll monitor up to 3 patients with 1 perfusionist. Once we get above 3, we add a perfusionist to the mix. So as a rule, we don't do it, but sometimes.
Have you any experience using sort of higher gas flows in terms of sweep and other bits with these oxygenators? And what do you feel with them?
No, normally, no. This guy, was a little bit of an outlier. Not so much because of his size. I think his disease process. We've put 400-pound patients on before with this device. I think our largest one was actually over 500 pounds. It was a VV ECMO, and we didn't have to run our sweeps that high. I think one of the things when you get into the larger patients is not so much the function of the circuit as the phenomenon of uncaptured venous return, right? We know that the net flow on VV ECMO is always 0, right? Because we're pulling out from the same basic place that we're putting blood into. So the net flow is 0, no hemodynamic support whatsoever. But there can be blood that goes around the circuit, which is uncaptured venous return. And so sometimes you have to employ strategies to capture more venous return. And I think that's a bigger function of why we get hypercapnic than inadequate sweep. Just empirical, not scientific.
Any further questions? No, in which case,
Thanks for your
thank you
time.
very much.